All right, I'm going to start recording now. We are live onto YouTube, but today is our bi-monthly meeting with UCSF and NorCal CarciNET. And I'm here with Lacey, who also works with us at UCSF. And we are both pleased to actually introduce Donald I. Abrams, who is a great friend of NorCal CarciNET. I started seeing Dr. Abrams shortly after my personal diagnosis of neuroendocrine tumor, pancreatic neuroendocrine tumor, when it was still not sure what my treatment case would be. So Dr. Bergslin recommended that I see Dr. Abrams to see what I could learn about other things I could do while I wasn't going under treatment. And that started actually a lifelong friendship between Donald and myself. It seems really hard to actually call him. He is a doctor, so I will remember to call him Dr. Abrams, but Donald and I have worked together in various different things, including when Donald was elected president of the SIO. I helped Donald with the Society of Integrative Oncology. Donald works at, or actually just recently retired from the Osher Clinic for Integrative Medicine at UCSF, but they knew what to do, and he has been invited back as emeritus. I lost Donald. 1 second. I need to find Donald again. Here we go. And Dr. Abrams has been a great friend of NorCal CarciNET over the years. So without further ado, Donald, you're on mute. You may want to unmute yourself, and the floor is yours.
Good. All right. Thank you, Josh. It's a pleasure to be here and to share with you some information about integrating cannabis into cancer care. Certainly a timely topic as more and more states are approving not only cannabis as medicine, but cannabis for recreational use as well. Now, hang on. So this is the Siberian Ice Princess. This is the body of a woman that was entombed for 2,700 years, very well preserved in the Siberian ice. In fact, her tattoos reportedly are being copied by millennials. The Ice Princess was put under an MRI and was found to be a woman probably in her mid-20s who appeared to have breast cancer that had metastasized to her bones. Around her waist was a belt, and at the end of the belt was a pouch in which were the flowers of the plant of Cannabis sativa, suggesting that 2,700 years ago, this woman knew that cannabis had some potential medicinal benefits. The anthropologists or archaeologists or whoever makes these sort of hypotheses suggested that the Ice Princess may have been using cannabis to relieve the symptoms of her metastatic breast cancer, or perhaps even to treat the cancer itself. I feel that that's a bit of a leap, and often the sort of leaps that we see in things that are published on the internet and social media, because we really don't know that everybody in that tribe might not have been buried with cannabis around their waist. Anyway, it does demonstrate, however, that cannabis has been known to possibly have medicinal benefits for about 3,000 years. It's felt that cannabis arose in northern China and moved along the Silk Route to the Indian subcontinent, and then further west into the Arab world, where it was used as medicine for 1,000 years. It was brought into Western medicine by a British East Indies surgeon, W.B. O'Shaughnessy, who was working in India and saw the potential benefit of cannabis in multiple different clinical situations. So he brought it to the United Kingdom in the 1840s, and later it reportedly became Queen Victoria's favorite treatment for her menstrual cramps. Cannabis made its way across the ocean to the US and was available as a medicine for physicians to prescribe at the beginning of the last century. And as you can see, many of the forerunners of what we now recognize as big pharma had cannabis products available for physicians to prescribe to patients. The interest in cannabis began to wane in the early part of the 1900s when individual, more targeted, if you will, therapies became available to address the symptoms that cannabis was useful for. The real death knell to the use of cannabis as medicine came in 1937 when Harry Anslinger, pictured here, a prohibitionist who was the first head of our Federal Narcotics Bureau, introduced the so-called Marijuana Tax Act to Congress, using the Mexican name to sort of do an end run around physicians. The American Medical Association, oddly enough, was firmly against this tax act because they felt that cannabis was a useful medicine and that this tax of $1 an ounce for medical use and $100 an ounce for recreational use in 1937 was going to be too much for patients to be able to afford. And in fact, the act passed and cannabis was removed from our formulary, the US Pharmacopoeia, in 1942. In 1961, the United Nations Single Convention Treaty defined cannabis as a dangerous narcotic. And this treaty still is abided by in most of the world. In 1970, the US Controlled Substances Act placed cannabis in Schedule I, which means high potential for abuse and no accepted medical use. And this is the company that cannabis keeps in Schedule I, where it remains to this day. Well, when I first became interested in looking at cannabis as a medicine, my oncology colleague said, gee, Donald, you know, in these days of nanotechnology and genomic therapies, why do you consider a plant to be appropriate? It's so non-specific. And it is true that the cannabis plant itself contains over 400 chemical compounds. The highest concentration of the bioactive compounds is present in the resin exuded from the flowers of the female plant. The main psychoactive component is believed to be delta-9 tetrahydrocannabinol, or THC, but there are at least 100, if not 150 other similar compounds called cannabinoids that are identified in the plant. For example, delta-8 THC in a study in Israeli children with cancer was found to be equally as effective as delta-9 THC in decreasing nausea in children receiving chemotherapy. Other non-THC cannabinoids that you will be hearing about, or certainly have heard about, include cannabidiol, or CBD. CBN is a breakdown product of THC and is felt to be somewhat useful for sleep. CBG in my Google alerts seems to be replacing CBD almost as the most favored non-psychoactive cannabinoid. One that's very interesting to me is THCV, or tetrahydrocannabivirine. This is a cannabinoid which seems to decrease appetite for food, tobacco, and maybe even opiates. So I think we'll be hearing more about that in the future if people are going to develop these individual cannabinoids as treatments for various situations. I will talk more about CBD as we go on. The non-THC components of cannabis are really there to provide the yin and the yang to the THC. They may enhance the beneficial effects of the THC and decrease some of the potentially disturbing effects. And in addition to the cannabinoids, other chemical compounds belong to the families of the terpenoids and flavonoids. The terpenoids particularly give the various strains of cannabis their different smells. And it's felt that these components of the plant themselves also have potential medical benefit. Raphael Mechoulam, who's the father of cannabinoid chemistry at Hebrew University in Jerusalem, believes everybody undergoing an acute stroke or other sort of head injury should be treated with cannabis to decrease the damage to the brain. And this is caught on, interestingly, in the National Football League, where the players are suggesting that they should be allowed to test positive for cannabis because they're trying to protect their brains from traumatic brain injury. So interestingly, we also make our own cannabinoids in our bodies. We have noted that the presence of two receptors, the so-called Cb1 or cannabinoid 1 and Cb2 receptor. These receptors are different and they arise from different genes on chromosomes, and they're not very similar in their genetic composition, suggesting that they arose for basically different reasons. The Cb1 receptor is one of the most densely populated receptors in the human brain. And whenever I lecture to a group of physicians, I say, how many of you learned about that in medical school? And never a hand raises. The Cb1 receptor is found throughout the body in green here in most organs and tissues. The Cb2 receptor was originally originally defined or identified in the spleen and in the blood cells that constitute the immune system, particularly natural killer cells and B lymphocytes. Since that time, it's also been found in other tissues of the body. And if it is in the brain, it's much less dense than it is the Cb1 receptor. So why do we have these receptors throughout our body? Well, it's because we make our own endogenous cannabinoids. Just as we make our own endogenous opioids, the so-called endorphins, we make endocannabinoids. The first one was identified and named anandamide after the Sanskrit word for bliss. The second endocannabinoid that was identified is so-called 2-AG, 2-arachidonyl glycerol. So why do we and all animal species down through sea squirts have this system of endocannabinoids and cannabinoid receptors? You've never seen a monkey or a dog smoking cannabis. Well, again, it's because we have these receptors. And why do we and all animal species have these receptors? Michael Pollan, the journalist in Berkeley who wrote the book Botany of Desire, explains in that book, in his chapter on cannabis, that these receptors help us to forget. So while I'm talking to you now, I'm not trying to remember where I parked my car or when the last time I gave this lecture was, so I can be here now. In his next book, The Omnivore's Dilemma, Michael is trying to gather his own food. And in one chapter, he's crouched in the woods with a rifle on his shoulder, holding very still, waiting to shoot a deer. And he postulates that the reason we and all animal species dependent on preying, E-Y-I-N-G, for our sustenance, have this system of cannabinoid receptors and endocannabinoids is to help us to forget pain. People have said that this is the system that allows women to want to have a second childbirth. So our endocannabinoids are synthesized on demand from membranes of our cells. And when their work is done, they're metabolized each by a different enzyme. When the endocannabinoids complex with the Cb1 receptor, they lead to changes in the cell that impact control of appetite, immune function, muscle, pain, intraocular pressure, cognition, nausea, etc. And when they complex with the Cb2 receptor, they're also involved with changes that impact on immune function, cellular proliferation, inflammation, and pain. And we know that the endocannabinoids also complex with the so-called vanilloid 1 receptor, where they're also involved with modulation of pain and inflammation. So Michael Pollan was probably correct that modulation of pain, or how we experience pain, is probably the main reason that we have this system of endocannabinoids and cannabinoid receptors. So I was one of the 16 members of the committee that was called together by the National Academies of Sciences, Engineering, and Medicine to review the health effects of cannabis and cannabinoids. And this is a 500-page document that we published in January of 17 after reviewing 10,000 abstracts in the medical literature that had been published since the last time the Institute of Medicine issued a review of the state of the art of cannabis. And there is 1 chapter on therapeutics and 13 chapters on potential harm. Now, why is that? The only legal source of cannabis for research in this country is NIDA, the National Institute on Drug Abuse. And NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So if you want to do a clinical trial looking at the potential health benefits of cannabis, you must use NIDA cannabis, but they cannot fund such a study. On the other hand, they spend $150 million a year funding studies looking at the potential adverse effects of cannabis. Hence, we had 1 chapter on therapeutics and 13 chapters on potential harm. So the strongest findings that we found in reviewing the literature were that in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective antiemetics. And in adults with chronic pain, patients who are treated with either cannabis or the oral delta-9 THC preparations that have been licensed and approved are more likely to experience clinically significant pain. We also thought that there was good evidence that patients with multiple sclerosis related spasticity also benefited from oral cannabinoids. So where does this come from that oral cannabinoids, i.e. delta-9 THC, was studied as a treatment for chemotherapy-induced nausea and vomiting? Well, in the 70s, that was Jimmy Carter was president, and it was prior to the Reagans and their Just Say No campaign, the war on drugs. Many more people were using cannabis, and young people with cancer getting young people's cancers, which are basically Hodgkin's disease and testicular cancer, were treated with pretty much the same regimens that we use today that are highly emetogenic. That is, they cause a lot of nausea. And our armamentarium of drugs for treating nausea was not as sophisticated as it has become today. So patients told us that, you know what, you can keep your prochlorperazine, cannabis works better. And this led the National Cancer Institute and a small drug company to investigate delta-9 THC, the main psychoactive component, as an anti-nausea drug. And it appeared in randomized trials to be better than placebo and equivalent to what was available at that time. So in 1986, the government approved dronabinol as well as nabilone as a treatment for chemotherapy-induced nausea and vomiting. Interestingly, the drug was expanded, the indication, to include treatment of anorexia or loss of appetite associated with weight loss in patients with AIDS. Well, that's an interesting advertisement. At the beginning of the 90s, before we had effective treatment for HIV, many of our patients died of the so-called AIDS wasting syndrome, where basically they wasted away with loss of appetite, diarrhea, and fever, and no identifiable infectious cause other than their HIV. This syndrome actually disappeared with highly active antiretroviral therapies. But in 1992, we didn't have those active agents and patients were dying. And up until 1992, the federal government, in all of its wisdom, was providing a handful of patients with so-called orphan diseases with 300 cannabis cigarettes a month in a canister because this treatment was felt to be beneficial for their orphan diseases. Well, the government got concerned that patients with the AIDS wasting syndrome would say that they qualify for being an orphan disease because there were less than 180,000 of them, and that thousands, if not tens of thousands of AIDS patients would be knocking on the government's door asking for 300 cannabis cigarettes a month. So Bush 1 terminated the so-called compassionate use program in 1992, and the FDA approved dronabinol for the treatment of anorexia associated with the wasting syndrome, because in the placebo-controlled trials, the dronabinol did not lead to increased weight, only increased appetite. But anyway, the government can say, you don't need medical cannabis, here's your cannabis. And that's when I started first to prescribe dronabinol to patients with HIV wasting. And they said, you know what, Donald, you can keep it. I prefer to smoke cannabis. It takes too long to kick in. And when it does, I get too zonked. And what the patients were describing was the difference between THC taken by mouth and THC inhaled. When taken by mouth, its bioavailability, how much gets into your system, is quite low. And the peak concentration in the plasma is reached in 2.5 hours. And it may remain elevated for several hours with a terminal half-life of 20 to 30 hours. That is the time it takes for half of it to be removed from the body. Most importantly, though, when taken by mouth, the first pass metabolism from the stomach takes the delta-9 THC to the liver, where it gets converted into an even more psychoactive metabolite. So I see a lot of older patients, particularly women with cancer, who say eating is good, inhaling is bad, and they go to the dispensary and they're told only eat a quarter of the cookie. And they do and nothing happens, so they eat another quarter and nothing happens, so they eat the whole cookie. And then they call me maybe 3 days later, possibly after a visit to the emergency room with a dysphoric reaction, saying they're never going to do that again. On the other hand, when you inhale THC, either vaporized or smoked, it's rapidly absorbed into the bloodstream, reaching a peak concentration in 2.5 minutes, and then it dissipates quite rapidly over the next 30 minutes. And because you're inhaling it, less of it is going through the liver, so you make smaller amounts of the 11-hydroxy psychoactive metabolite. So I tell patients if they want better control over the onset, the depth, and the duration of the effect, I think smoking is better than oral ingestion. And when I say smoking, I mean inhaling or vaporizing, but I don't mean vaping, because I am an oncologist and we tend to be quite conservative. And I know the long-term effects of inhaling plant material, but the long-term effects of inhaling an oil, in my mind, are unknown, and it can be quite dangerous, as we have seen. Nowadays, if you go to a dispensary, you'll see that there are many, many other options besides flowers to be inhaled or agents to be ingested. By the way, as an oncologist and an integrative oncologist, my #1 no for my patients is sugar. So I don't believe that baked products or gummies are very healthy for people living with and beyond cancer, because they're mainly sugar. Nowadays, we have tinctures and oils that are put in the mouth. And when you put a liquid in your mouth, you absorb some immediately from under the tongue, and then you swallow the rest. So you get sort of a hybrid kinetics between inhalation and ingestion. So again, I tell patients if they find a product that works for them, it should hopefully be a tincture or oil, so that they can get sustained levels and the benefit of more immediate onset. People have made and available in dispensary are rectal and vaginal suppositories. People do believe that these work. They tell me all the time that they definitely get an effect, although Mahmoud El-Souleh, who grows cannabis for the government, believes that only in a hemisuccinate form can it be absorbed from the rectal mucosa. People also benefit sometimes from applying cannabis topically or patches through the skin, although I don't think we know enough about how much of that actually gets absorbed into the body. But needless to say, there are many different options now for cannabis delivery. With regards to nausea and vomiting, though, I am a big fan of cannabis. Ondansetron, which is one of the most widely used antiemetics, causes constipation. And I find that patients with cancer do not really want to tolerate constipation. This is an email received a few years ago when I had to write annual letters for patients from a 48-year-old patient with metastatic colon cancer asking for a renewal of his cannabis approval. Although I did not use it until my last 5 sessions of chemo, me getting over the stigma of its use, it did what no other drug could do, completely solve the severe nausea I had. It allowed me to play with my children, attend their sports and school functions, and just function very normally in day-to-day activities. I cannot thank you enough for giving me that option. I'm currently on a chemo vacation after a clean scan, and the only time I use medical marijuana now is when I have trouble sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceutical options. Well, interestingly, despite the anecdotal evidence that cannabis is very useful, even Melissa Manchester said it's the only thing that allowed her to tolerate her adjuvant chemotherapy for her breast cancer. The American Society for Clinical Oncology expert panel recommends only the FDA-approved cannabinoids to treat nausea and vomiting that's resistant to other treatments, and the evidence remains insufficient to recommend marijuana in this setting. And I think that is an unfortunate guideline from my parent organization. Well, what about pain relief? I mentioned that it's probably the reason that we have this whole system of cannabinoid receptors and endocannabinoids. If you give THC by vein, it's really a potent analgesic. The cannabinoid-induced pain relief appears to be linked to the opioid system, but they're quite separate. And cannabinoids are also effective in a rat model of neuropathic pain, that is pain caused by nerve damage. We did a study back in the day when AIDS patients were taking drugs that damage their nerves and told us that cannabis was useful for decreasing this pain. We did a placebo-controlled trial of smoked cannabis cigarettes in patients with this HIV-related sensory neuropathy. We had patients keep a diary for 7 days as an outpatient, scoring their pain. And then all of our studies have been done in our inpatient general clinical research center. So we allowed the patients to adjust to being admitted into the research center for 2 days. And then on each of the next 5 days, they smoked either a cannabis cigarette or a placebo cigarette. And what we found was that cannabis reduced pain. Well, we said what percent of patients have a greater than 30% reduction in their pain. And for the cannabis group, it was 54%, and the placebo group, it was 24%, demonstrating that cannabis was in fact effective. So we calculated that the number of patients needed to be treated with cannabis to achieve a reduction in their pain would be 3.6, which was the same number needed to treat from another study of gabapentin or Neurontin, which is an anti-seizure medicine that's quite widely used for neuropathic pain. So when we published our study, Todd McArea, who was a cannabis clinician in the East Bay, he ultimately died of lung cancer, but he collected these labels from cannabis preparations from the early 20th century. And he thanked me for proving what we already know, what we knew 100 years ago, that cannabis is a neuralgic, i.e. useful for pain from nerve damage. Well, we know that chemotherapy induces the same peripheral neuropathy that's painful. And studies in rats and mice have demonstrated that the 3 different classes of drugs that cause neuropathy in cancer treatment, the vinca alkaloids, the platinums, and the taxanes, not only can we treat with cannabis-based chemicals, but we can actually prevent the neuropathy from happening. So that is pretty exciting, but has not yet been studied in humans. Now, another area that we have a lot of information from animal models is the fact that cannabinoids interact with the opioid pain relievers in a fashion that's synergistic, such that 1 + 1 = 5 and not 2. And this would allow for the possibility of enhanced and persistent pain relief at lower opioid dosages. So we did a clinical trial, actually got cannabis from the government, and the government paid for the study. Why is that? Well, I said I wanted to see if it was safe for patients on sustained release morphine and sustained release oxycodone to add vaporized cannabis to their stable opiate regimen. So as long as I was determining whether it might have harm, NIDA paid for the study. But since everybody did have pain, we also sort of snuck in an assessment of what vaporized cannabis did on the level of chronic pain. Now, I mentioned that I was anti-vaping, but vaporizing is okay. So we had previously studied this Volcano Vaporizer as a smokeless delivery system, largely because I felt most of my oncology colleagues would not really, consider smoking a cigarette as a 21st century drug delivery system. So the so-called Volcano Vaporizer, because of its shape, is basically a heating element with a fan, and cannabis is put in this chamber and put on top of the heating element. And then there's this valve that blows up what used to be in the original incarnation of the device, a turkey roasting bag. And there's a one-way valve here so that it doesn't deflate unless you exert pressure and inhale. So that's what we have used for all of our clinical trials at Zuckerberg San Francisco General. So because this was a safety study and essentially a pharmacokinetic interaction study, where we were looking to see if adding vaporized cannabis changed the plasma levels of the opioids in the bloodstream, we only needed 10 patients per arm. We ultimately enrolled 10 on sustained release morphine and 11 on sustained release oxycodone. And as I mentioned, we did check their pain. The morphine group came in with an average pain score of 35 on a 0 to 100 scale. The oxycodone group came in slightly higher at 44. And these curves show what happened to the levels of the opiate in the bloodstream. On the left is morphine, and the top line is the first day before exposure to vaporized cannabis. And the bottom line is the 5th day after they had been vaporizing cannabis 3 times a day. And it looks like the morphine levels are lower, although the error bars here cross, so it was not statistically significant. The oxycodone curves are entwined, suggesting that there was no real change in the plasma concentration of the oxycodone. So if the level of the opiates stayed the same or decreased, you would expect pain to stay the same or increase. Well, the average pain for the group on day 1 was 40, and on day 5 it was 29. And that represented a statistical significant 25% reduction in pain. The morphine group actually had a 33% reduction. The oxycodone group slightly less, a 20% reduction. But this study was too small to evaluate pain as an endpoint effectively, but it certainly demonstrated a trend that adding cannabinoids to opiates did provide some additional pain relief. And it appeared safe as well. The government required us to measure oxygen by way of an oximeter on the finger throughout the time the patients were hospitalized day and night, because the fear was that if cannabis increased the blood level of the opiates, that might shut down the respiratory drive and let people oxygen levels lower. So there is an interaction, but it's not pharmacokinetic, as it were, because it's not because the cannabis raised the plasma levels of the opioids. So this is interesting and warrants further pursuit. And again, in the early 1900s, morphine and cannabis were together in a medicine. I think it's poison because the chocolate, personally, but that's only my impression. So sort of supporting this fact that cannabinoids, number one, have pain relieving activities, and number two, may allow for lower prescribing of opiates, is this data from states where cannabis has been approved, showing that in those states, there's a decrease in medications for pain, anxiety, and nausea, etc. So one other indication that I used to approve cannabis for patients for in the days before it became available more widespread as recreational use were women with estrogen receptor positive breast cancer. This chart shows you the linear relationship between the number of alcoholic drinks consumed a day and the risk of developing estrogen receptor positive breast cancer. I see a lot of women in my practice who are survivors of estrogen receptor positive breast cancer, and they're back to work. And when they finish work in the old days, when people used to go to the office, their colleagues would say, let's go out for a drink. In the old days when we had bars. And in the old days, when the patient would come home from work and her husband would come home from work, he would say, let's have a cocktail. Well, I saw many women who said they would prefer not to consume alcohol. And can I write them a recommendation so that they can have cannabis to be socially lubricated? And I would do that quite readily because I believe cannabis is much healthier than alcohol. So what about CBD? CBD really was brought to the attention of the world by Sanjay Gupta. Interestingly, cannabidiol was actually identified in the plant prior to THC, but really, because it didn't seem to do much, had not received the attention. And when I say didn't seem to do much, didn't seem to have much psychoactivity, didn't get people high, was not sought after for any particular reason, until Sanjay demonstrated Charlotte Figge, recently deceased, going from a child with uncontrollable seizures to a healthy toddler after being treated with drops of CBD. And this led ultimately to clinical trials studying CBD in patients with epilepsy, children particularly, and leading to its approval as a pharmaceutical. The information on the beneficial effects of CBD are really derived predominantly from preclinical studies in the test tube and in animals because few clinical studies of cannabidiol actually exist. But it's touted to be anti-inflammatory, against pain, nausea, vomiting, antipsychotic, decreases anxiety, and of course is now felt to be anti-epileptic. However, if you look at the published clinical trials, in 1986, somebody published a study on 5 patients with an unusual movement disorder called dystonia and said that they had some improvement. However, the same investigator later published a study on 15 patients with Huntington's chorea, another neurodegenerative disease, and found that they were not helped. 24 participants with generalized anxiety disorder is actually the largest clinical trial published prior to the epilepsy studies. In this study, 12 participants with general anxiety disorder received CBD, quite a large dose, notice, 600 milligrams, and 12 received placebo prior to a simulated public speaking event. And the 12 patients receiving the CBD were less anxious during that simulated public speaking event. Again, that is the largest trial to date, and it's not a very big trial. 12 participants inhaling CBD reduced their intake of tobacco more than 12 on placebo. And there was possible improvement in quality of life in 21 patients with Parkinson's disease receiving placebo 75 or 30 milligrams. So, you know, you can see the CBD products that are out there are often 10 milligrams, and the studies that showed benefit actually were looking at much higher dosages. So it is shocking to me that CBD sundaes are sold at the Ferry Building in San Francisco when we used to be able to go there, and CBD infused clothing is also now available. And most recently, last week, in the Polish Zoo, CBD is given to elephants to help stop their anxiety and aggressiveness. So I'm curious to see the outcome of that intervention there. The biggest question that I'm often asked is, what is the right ratio of CBD to THC that I should consume? Well, CBD-mediated attenuation or decrease of THC-induced effects is observed when the ratio is greater than 8:1, and potentiation or increasing THC-induced effects is seen when the ratio is about 2:1. All of that data comes from rats and mice. There is absolutely no information in the medical literature on varying ratios of CBD to THC other than a ratio of 1:1, which is what nabiximols, the sister drug of Epidiolex, the CBD preparation that was approved for epilepsy, actually is. Nabiximols is a whole plant extract of the cannabis plant modulated to have a ratio of 1:1 CBD to THC. And this drug is licensed and approved in Canada, the UK, and the European Union for treatment of spasticity related to multiple sclerosis. They have tried on a number of occasions to look at this drug in cancer pain, and none of the studies demonstrate that it actually is better than placebo. So that's why this drug has not yet been approved in the US. However, that doesn't stop the people who are selling CBD, which is now a $23 billion industry in this country, from making very fancy charts like this, showing what the different ratios actually produce in people. You know, again, I don't know where this data comes from. The plural of anecdote is not evidence. It disturbs me that CBD has so much industry behind it without a lot of evidence. We actually did a survey of 400 people in San Francisco, San Diego, and Chicago at our 3 integrative medicine centers, as well as 10 dispensaries in those 3 cities, asking people using CBD dominant products what they were using, if it worked, how they used it. And again, predominantly pain, anxiety, and insomnia were the most frequent reasons people were using it. And mainly they were using oils or tinctures, very few actually smoking or vaporizing the flowers. So, and of these respondents, when asked effect on symptoms, the average was 8 out of 10 benefit. But that doesn't mean that CBD cures cancer. And I think these websites saying cure your own cancer with CBD are really criminal, to be honest. We found in our review from the National Academies of Science, Engineering, and Medicine that there was no evidence that cannabinoids have anything to do with curing cancer. In fact, we were told to only include human studies and meta-analyses of human studies, but we had to divert in our section on cancer because there were not human studies. We do know that cannabinoids added to brain tumor cells in the test tube kill those cells. My friend and colleague Manuel Guzman in Madrid has a laboratory that studies the effects of cannabinoids on metabolism. And the most metabolically active cells in the body are brain cells. So they would grow up rat brain and add their cannabinoids and study. And they said, maybe we can do our work faster if we grew up a brain tumor. So they grew up a rat brain tumor and they added the cannabinoids and everything died. And they said, ooh, maybe we did something wrong. So they did it again and everything died. So they went back and said, maybe these are a bad batch of cannabinoids. They went back to the normal cells and everything lived. So now we know from multiple experiments that have been done and reported in the medical literature that cannabinoids selectively kill brain tumor cells, probably by interacting with that Cb1 receptor, which is so densely populated in the brain. And in addition to having direct anti-tumor activity, cannabinoids block vascular endothelial factor, or VEGF, which allows new blood vessels to form to supply blood so that the brain tumors can grow. And we also have demonstrated that cannabinoids inhibit an enzyme that allows cancer cells to become invasive and spread. All of that in the test tube. So cannabis doesn't cure cancer. Well, does cannabis cause cancer? Well, we reviewed all that literature as well, and we concluded that there's moderate evidence of no statistical association between cannabis smoking and lung cancer. And there's also moderate evidence of no statistical association between cannabis use and the incidence of head and neck cancers, which are certainly increased in people who smoke tobacco. There was seen limited evidence of a statistical association between cannabis smoking and testicular tumors. Well, that's interesting. How would cannabis cause testicular tumors? Well, if you look carefully, it says a statistical association, and it does not necessarily imply causation. We had a guy come to speak to us at the National Academies from the National Safety and Transportation Group. And the question was, in states where cannabis is legal, are there more automobile accidents? And he explained, yes, there were, but if you made an adjustment, they disappeared. He said, who gets into automobile accidents? Young men. Who smokes cannabis? Young men. So if you do a statistical adjustment for that, then there's no increased risk. Similarly, who gets testicular cancer? Young men. Who smokes cannabis? Young men. So there is a statistical association, but it does not imply causation. It's very similar to the observation that there are more drowning deaths in months where ice cream is overconsumed. True, true, and unrelated. So when I go to meetings of people that are working with mice and shrews and monkeys, they often describe euphoria as a side effect of cannabis treatment. So maybe it's a side effect, but is it really an adverse experience? Clint Werner, my husband, wrote the book Marijuana Gateway to Health, How Cannabis Protects Us from Cancer and Alzheimer's. And he made up a new word in that book. And I sort of forgot that word and I made up a companion new word. We are residents of a Puritan-derived Judeo-Christian society, and we suffer from, one word is his, one word is mine, I can't remember which and which, euphorophobia or euphoranoia. We don't believe that being high is something that you should strive for. I say, is a single treatment that increases appetite, decreases nausea and vomiting, relieves pain, and improves sleep and mood a potentially useful tool in oncology? And I think it is. And I ask all of my patients here at the Osher Center, what brings you joy? And the number of people who tell me that gardening brings them joy is not insignificant. I believe if you have cancer and feel that part of you has died or that you might be dying, the ability to bring life out of the ground is a blessing. And if you can grow your own medicine, that's very empowering. So we come to the day of smoke 2 joints and call me in the morning. Well, I don't think so, but we are pretty sophisticated. I mean, we have dispensaries in San Francisco that are quite elegant, and that advertise in San Francisco magazine. This is the inside of a dispensary. You can see selling the Volcano Vaporizer as well as a smaller version. And they provide, different products. Sun-grown, Clint, my husband, is a cannabis connoisseur. After he wrote his book, he got tapped a number of times to judge the High Times Cannabis Cup. And when I asked him, why do they label indoor versus outdoor? He said, where would you prefer to get a suntan? On the beach in Maui or in a tanning salon in downtown San Francisco? So he's a big aficionado of outdoor grown, saying that sunlight and air is a lot better than fluorescent lights and a fan. Then this menu tells you whether the plant is Sativa or Indica. Most of the strains that you get in a dispensary are a blend of Sativa and Indica. It's felt that Sativa is much more up and mental, and Indica is down and physical. So if you're trying to go to sleep at night, you probably would like an Indica dominant over a Sativa dominant blend. And then they also tell you what percent THC to CBD. These two are high THC, and this one is a higher CBD. And then they give you a wine spectator like one-liner, a bright and cerebral sativa with euphoric overtones. So we are quite sophisticated in our menus here. And are we reaching a tipping point? Well, here's a Life magazine cover story. Marijuana, at least 12 million Americans have now tried it. Are penalties too severe? Should it be legalized? The date, October 31st, 1969. So we've been having this conversation for quite a while. And when my colleagues in oncology say, gee, Donald, in these days of nanotechnology and genomic therapies, why do you continue to study a plant? I say it's to get us back to the roots of medicine. And with that, I'll stop. And I guess I'm happy to answer any questions if we're set up to do that, Josh.
We do have a few questions in. I also want to throw up a poll real quick.
Throw up, don't say throw up.
Yeah, that's true. Probably true. Let me see if I can bring that poll up real quickly. Launch poll. Apparently not. I was going to see how many people in the audience had actually worked with different medicinals or medicinal cannabis, but for whatever reason, my poll thing isn't allowing me to do that. So there are a few questions up in the Q&A, and hopefully some more will come in. One of the questions was about masking pain and what that may do, and I would think that would be the same with opioids and other things as well. Is there a challenge in masking too much of the pain that we don't understand what the underlying condition is that's causing that pain, or how do we look to make sure we don't mask too much pain and not know, or is there such a thing as masking too much pain?
Well, I think it's always best to know where the pain is emanating from or what's causing the pain before you treat it. So I would say the answer to that is no. I mean, you should figure out what's causing the pain and then treat it. And, if cannabis is useful in the treatment of that pain, so be it. I don't think people should experience pain if they don't need to.
That's great. Listening to the conversation or listening to your presentation, one of the things that, and I know the plural of anecdotal is not evidence, but how do we get there? How are we going to, how many studies are going right now to try to at least, answer this and so we can get some idea of to the evidence? I mean, where are we in that?
I'm just putting together a talk that's going to be recorded on Friday for the International Association of Cannabinoid Medicine Conference, which is going to be virtual. I'm doing it with Manuel Guzman, my friend in Madrid, who I mentioned. And he's doing the basic science part. Cannabis is an anti-cancer agent, and I'm doing the clinical part. And there are no studies, Josh. Nobody. Manual is doing another study of THC, CBD in patients with brain tumors, glioblastoma, which has already been done a few times, and it may work, but there are no other studies. Dylan Zilla is a doctor in Minnesota who's collecting evidence or stories from people who claim to have cured their cannabis using highly concentrated oils so that he can collect them and review that data. Because so many people say that they cured their cancer using highly concentrated oils of THC and CBD, and there's no evidence of that in the medical literature. It's all online, all anecdotal. And, you know, he's giving people an opportunity to send in your information and let us collect it. Because I see the next question is about somebody using an oil and calling it a name that I don't use for that because it's the name of a man who's on the lam. So why would we acknowledge him by using his name on this oil? There's no evidence. There's just no evidence. It's all anecdote. And, you know, I like to quote Zoe Lufgren, who's a congresswoman from the Bay Area, who I saw on the news. I don't watch news in general, but I saw her, and she's been involved in all three recent impeachments. And they asked her if there was anything different about this one. And she said, why, yes, we live in an age where the media allows for multiple realities to exist, even when the truth is known. And I think that's what people suffer from. And I really feel badly for my cancer patients who in their desperation are wanting to believe something will work that doesn't.
Yeah, and obviously that's more than just cannabis in this case. There are many things that we've certainly talked about over the years that are like that. Any indications for those who are over 75 and working with cannabis and you know, controlling pain, nausea, and other things? Any things they should be looking up for?
Yeah, well, I think older people, if they're at risk for heart disease, should be careful because cannabis, particularly THC, can increase the heart rate, and it could increase or decrease the blood pressure. And people may be familiar with standing up too quickly and feeling dizzy. And in older people, that may lead to falling down, and God forbid they break a hip, that becomes a problem. So I think older people, I often caution to go easy, especially if they're cannabis naive and if they have heart issues.
So the one on the top now in the kind of questionnaire is on someone who's vaping and for sleep pain and nausea. And I know we talked about vaping, you talked about vaping a little earlier. If someone wants to change from vaping to something that, well, I mean, you've talked about oils and or tinctures and the Volcano, which I think is a unique, interesting concept for vaporizing the cannabis as well. Recommendations for those that are vaping to get off vaping because of the challenge of the oil?
Yeah, I mean, if vaping, you know, when I submitted my most recent study to the New England Journal, they said, why would they even consider having sickle cell patients vape? And I was not vaping, I was vaporizing.
Right.
So there are portable vaporizers, much smaller and much more user-friendly than the Volcano that people can buy, where they vaporize the plant material and not an oil. And then there's nothing really wrong with smoking or doing. Clint is a major bong user. A water pipe is fine, or a small pipe. There's no evidence that it increases the risk of lung cancer or head and neck cancer, or any cancers for that matter. So again, if you want better control over the onset, the depth, and the duration of the effect, inhalation is better than oral ingestion. But again, the oils and tinctures, as you mentioned, give you that hybrid, because when you put a liquid in your mouth, you absorb some immediately from under the tongue, and then you swallow the rest. So,
looking at that connoisseur map of the menu at one of the stores, one of the questions that I have for you is that, if you're not an expert in this, how do you go about looking? You gave some indications of what the various Indica and Sativa were for, but how do you actually go about figuring out what's the right thing, or do you buy sample packs and see what works effectively, or what's the right thing to work for you?
And that's a good question, because I, as a physician, have no idea what's available in the dispensary because I don't frequent a dispensary. So I tell all my patients, go to the dispensary, tell them who you are and what you're treating, and ask them what works best. And usually those bud tenders know a little bit about their products and can help. I did have two PharmDs, graduates of the UCSF School of Pharmacy, come to talk to me a few years ago saying, how would you like it if we opened a dispensary? And I said, yeah, that would be cool. Well, they came back a year later and said it costs $1 million to open a dispensary. So they opened something called Med1 Specialty Care. And there are two pharmacists, and they talk to you. It's a concierge service. So they talk to you, and I think I don't know what the fee is. It's a monthly fee of like $99. And they ask you who you are, what you're taking, what pharmaceuticals you take. And then as part of that monthly fee, they will send you a tincture that they devise specific for your needs. Many of the patients I deal with who don't want to go to a dispensary have been very satisfied dealing with Med1 Specialty Care. And I will, in the spirit of full disclosure, say that I am an advisor to them, but at this point in time, I have no financial relationship with them. But
you brought up an
interesting
point of also understanding what you're taking and how that may interplay with the drug. Because you clearly, the one study you pointed out is VEGF, and many of us who are NET patients may be on a VEGF inhibitor already. Is there any counterindications or things? And I know this is a generalized thing, and you should always talk to your treating physician. So this is a much larger question, but how do we look at counterindications for when this might interfere with some other therapy that we're on?
Well, that's a great question. And, both THC and CBD work in the liver on the enzyme system that breaks down other pharmaceuticals and other botanicals. And that's one reason I particularly worry about patients taking highly concentrated oils of THC, CBD, or both, because CBD particularly inhibits those enzymes which break down other pharmaceuticals. So in fact, the Epidiolex CBD drug that's anti-seizure is only approved in the European Union in conjunction with a traditional anti-seizure pharmaceutical, because they believe that the way it works is by blocking the metabolism or breakdown of that pharmaceutical so that it reaches a higher level and hence is more effective, and that it itself is not really anti-seizure. So I fear patients who are taking cancer treatment, taking highly concentrated CBD, particularly, or THC, because it might interfere with their pharmaceuticals. The only study that's published right now about a potential negative interaction is in Israel in patients receiving the immunotherapy nivolumab. In a retrospective study, patients who received nivolumab, 89 patients received only nivolumab, 54 got nivolumab and were using cannabis. And they found that those who were using cannabis had less of a good response to the immunotherapy, although their survival was exactly the same. So I caution patients who are going to be using an immunotherapy about that data, or let them know about that data in case they want to act upon it. But again, it's a little hard to understand because, the response rate to the immunotherapy was decreased, but survival was the same.
I want to be appreciative of your time and know that you have other things doing as well. One last question. When do you think this will be something that will commonly be available and when you're in a hospital stay for treating pain?
Yeah, that's a long way away. I mean, certainly hospitals are not places where you're going to smoke or inhale something. Well, you inhale, actually do make asthma-like inhalers that have cannabinoids in them now. So, I don't know. I mean, I used to say not in my lifetime in an answer to the question, will cannabis ever be legal? But now I don't say that anymore because I don't want to shortchange myself, right? Because it seemed like we've reached a bit of a tipping point.
So I want to thank you again for your time and all of this. And I want to remind people that you are still seeing patients at the Osher Center at UCSF. How often do you see patients now?
I'm here 3 mornings a week, Monday, Tuesday, and Wednesday. My free and 4-day weekends.
Wherever here is in these screens that we're all using now, or are you seeing people physically, or are you it's all over Zoom?
Yeah, no, I do a lot of Zooming, but every once in a while somebody appears and they put them in an exam room and then have to get off Zoom and there is an option to be seen, but it's when I don't put in my hearing aids, I can't really understand what people are saying when they're behind their mask. So it's better right now that I Zoom.
Again, thank you so much for your time. We hope you are able to get to your next eclipse later on this year, and we hope to one day join you on one of these eclipses, although we've done one certainly
2024 it goes through Texas all the way up through Cleveland in April. So
I think that's one to do. I'm going to stop our live stream